Good day and very welcome to this series of lessons about the partograph. I'm Anna Nolte and I'm going to teach you on this. The name of this series of lessons is Assessment During Labour Using the Partograph. And then in the different lessons, there are going to be 5 lessons, we will discuss the different aspects of the partograph. So in lesson 1, the partograph in general will be discussed, and then in that lesson and the following lessons, we will discuss the fetal condition, the progress of labour, the contractions and the maternal condition. And then in lesson 4, we will discuss the 4 Ps and how to use the 4 Ps in the interpretation of the partograph. And then lesson 5, in my opinion, is the most important lesson in this series, and that is how to interpret the partograph. Because we find that very often midwives can fill in the partograph 100% correctly, but then when it comes to the interpretation of the partograph, they lack knowledge. So hopefully in lesson 5, we will teach you on how to interpret the partograph. Okay, so in this lesson, lesson 1, we will then discuss the partograph, as I've said, in general, and then also fetal condition. Now, the objectives of this series of lessons of the whole partograph will be to explain the principles of the partograph as a tool for preventing fetal and maternal complications during labor. How, by using the partograph correctly, can we obtain this objective? To monitor the fetal and maternal conditions as well as the progress of labor, and to record this accurately on the partograph. To be able to interpret the partograph, as I've said previously, and recognize any deviations from normal, which is the most important aspect. And then also to describe the specific and the correct midwifery actions at the appropriate time according to the assessment that you have done previously. And then to decide on a timely referral. And this referral doesn't necessarily mean referral from a clinic to a hospital, but it also means the timely referral of a patient to a doctor by calling the doctor in time. Now, why is it important to use the partograph? What's the importance of the partograph? It's a very easy assessment tool to use. With the use of the partograph, the progress of labor, the fetal and the maternal conditions can be seen all at one glance. You look at the partograph, which we will look at just now, and you can see exactly what's going on at a certain time with the fetal condition, the progress of labor, the condition of the mother, etc., and to make your conclusions from this. We can also use the partograph very effectively to determine how the labor is progressing, and we can easily see if there's a failure of progress of labor. And as we have said previously, it can also help the midwives in their referral decisions. Referral for the patient from a clinic to a hospital, but also letting doctors know in time about certain abnormalities, problems, etc. Then also it decreased the maternal mortality and morbidity due to obstructed labor, because obstructed labor might cause maternal mortality and maternal death due to a ruptured uterus. It can also lead to maternal health if a cesarean section has been done, and it might have been done too late in the case of prolonged labor. And then also postpartum hemorrhage and postpartum sepsis are also possible complications of prolonged labor. Just before I come to the different components of the partograph, I just want to give you a little bit of background on different partographs, the development of the partograph, where the partograph is coming from, etc. Now, the partograph, the initial partograph, has been developed many years ago by a certain Professor Philpott. He, at that stage, was working in Zimbabwe, and he saw that the women in the rural areas, many of them have maternal mortalities because of obstructed labor and not being referred in time to a hospital so that the cesarean section could have been done, etc. So he developed this instrument to be able to assess the patient correctly and make decisions timeously to prevent the mother from dying. Then after that, there's been several types of parthographs developed by the World Health Organization, and all of them consist more or less of the same components. The partograph that I will discuss in this series of lessons will be the partograph that has been developed by the Department of Health. This is the latest partograph that has been developed. And then also many of the private hospitals have developed their own partographs, but they all are being based on the same principles, and they all consist basically of these 5 components. And there are also some general guidelines on what they consist of, which I will come to as we discuss the progress of labor. So there's the timeline, the fetal record, the record of the progress of labor, the maternal record, and the medication treatment area, as we've said previously. And now every single part of the partograph will be discussed separately on the following slides. I will do the fetal record, the record of progress of labor, etc. Good, so here you can see half of a partograph. A partograph is usually over 2 A4 pages or an A3 page. So there's another part of the partograph coming. It's been printed in the maternal book, and it's been over 2 pages of the maternal book. And I will show you just now the other part of the partograph as well. So and as I've said, there are different partographs being developed by the World Health Organization. In South Africa, we have the one that's been developed by the Department of Health, and then many of the private hospitals have developed their own partographs, but they are all based on exactly the same principles, and we will talk about the principles now. So in here, and on the top of the partograph, we have all the details of the patient, name, age, gravity, parity, etc. Then we have a timeline, and we will talk about the timeline separately. We have the time that we write down when we are doing our assessments and recordings, and then the duration in hours. So if we start, for example, our partograph at 2 o'clock, and 4 hours later, it's now 6 o'clock, then we will record here 1, 2, 3, 4 hours. So that shows you how long the patient's been in labor. Then we have this part that is the fetal condition part, where we record all the fetal observations. We have this part where we record all the progress of labor records, and then we have recordings, and then we have this part where we record the contractions. This is the second page of the partograph, and here on top you will see the maternal condition, where we record the vital signs of the mother, the urine output, etc. And then here are some blocks for the medication that's been given, the pain management, and then signature and rank here at the bottom. So here you see an example of a partograph that's been filled in already. On top you can see the timeline, the times that the patient have been observed. Here was 10 o'clock, here was 2 o'clock. Then this has been transferred to the active phase of labor, which we will come to in the next part of slides. The fetal observations being recorded here, 4 hourly during the latent phase, half hourly during the active phase. the other observations regarding the fetal condition, the membranes, the variability, etc. And here is the progress of labor, the cervical dilatation and engagement of the fetal head has been recorded here. We can see that there's prolonged labor. Here are some further observations regarding the progress of labor, the engagement, effacement of the cervix, the station of the head, the contractions, and how strong and how many contractions, the frequency of the contractions, and the maternal condition. Now, the timeline, as I've said previously, all the recordings on the partograph are being made according to this timeline, because we have to indicate, like in all records, that we are doing at what time we are doing the record, and this duration in hours tell us then the number of hours that have passed since the partograph was started. And we will see that again on when we come to more examples of the partograph. So if we start the partograph at 2 o'clock, the patient has been admitted and she's in labor, we start the partograph at 2 o'clock. So this block will say 1 hour later, 2 hours later, 3 hours later, and that's basically how we use the timeline. Now this part of the partograph we use to plot or record all the fetal condition aspects. This represents the fetal heart rate and different aspects regarding the fetal heart rate. The heart rate itself, it should be done before and after contraction, the variability of the fetal heart, the decelerations of the fetal heart, and then the liquor, whether the membranes have been ruptured or not, and then what does the liquor look like. It is, if the membranes are intact, we will record it with an I, and if there's meconium in the liquor, we will record it with an M, and we will come to that just now as well. Now, the mother is this, we divide labor in a latent phase and an active phase, I think, as all of you know, and we will come to the different aspects of the latent phase and the active phase in more detail when we are doing the progress of labor. But what is important is that, and what one should remember and know, is that when the mother is in the latent phase, observation should be done at certain intervals, and when mother is in the active phase, it should be done in certain other intervals. So when the mother is in the latent phase, we should do the fetal, we should auscultate or do fetal heart rate assessments 4 hourly, and then when the mother is in the active phase of labor, this should be done half hourly. And these time spans here is according to the maternity guidelines that have been developed by the Department of Health, but this is also more or less the same time intervals that's been used in most of the private hospitals and in most of the guidelines that private hospitals use as well. So this is a fairly general principle of time intervals when we are recording or assessing the fetal heart. So it should be done 4 hourly in the latent phase, half hourly in the active phase, or continuously with the CTG if there are any problems and if fetal distress is being suspected. So when we look at in more detail at the recording of the fetal assessments, first of all, we look at the fetal heart rate. And if we look at these numbers here, that's an indication of the fetal heart rate, and we record it according to that here from 90 to 180 beats per minute. So if the fetal heart rate is 130 beats per minute here at this instance, then I will record it here as 130 beats per minute at this instance. Now, what is very important regarding the heart rate is that we should record it before and after a contraction. It should actually be recorded before, during, and for 30 seconds after a contraction, but we record it then here on the partograph as before a contraction and after a contraction. We record it with a O or a 0 or a circle, the fetal heart rate before a contraction, and then with the X after the contraction. So here, for example, the fetal heart rate before a contraction was 145 beats per minute, but now after the contraction, it's 140 beats per minute. Now, what is very important, and the reason why we are doing it, and we will come to that more closely just now as well, the reason why we are doing it is to be able to pick up decelerations in the fetal heart. So if we record these before and after fetal heart rates, one should be very careful to observe and note that if there's a difference of 15 and more beats per minute between the before and after fetal heart, after contraction fetal heart, it might be an indication of decelerations and should be followed up by a CTG recording of the fetal heart. Now, just before we go further with the recording of the fetal observations on the partograph, just a little bit of a revision of what happens with the fetal heart and the fetal blood flow and the fetal oxygenation during contractions, during labor in other words, and why it is so important to record the fetal heart rate or fetal heart observations correctly on the partograph. Now, this diagram here that you see here in front of you is cut through the placenta. Here is the uterus with the umbilical cord and the fetus here in the uterus, and this is the placenta. This yellow part is the muscle of the uterus, and this is the placental part here with the villi being surrounded by the maternal blood. Now, for those of you who have done the CTG course, we have said that when the uterus contracts, the moment that the uterus starts contracting, these spiral form arteries from the mother that goes into this intervillous spaces and surrounds the villi with oxygenated blood from the mother is being compressed during a contraction. So when the uterus starts contracting, the blood flow to this intervillous space is being cut off. So during a contraction, no new oxygen goes to this intervillous space, which is very important for us. Normally, a normal fetus can cope with this. But if there's already intrauterine growth problems, or when the labor is prolonged, that this progress is going on for a very long time, or when there are many contractions, the frequency of the contractions are quite high, so there's not really a proper relaxation period between the contractions so that new oxygenated blood can go to the placenta. Eventually, the fetus might develop hypoxia. And that is, as I'm saying, so important, and the reason why we need to do fetal heart rate observations before a contraction and during a contraction. Because if there is hypoxia here in the intervillous space, we might get the development of decelerations, and we have to pick that up with our observations of fetal heart. And this is why then it is then so important to do half-hourly observations of the fetal heart during the active phase of labor when the contractions are so strong. Now, if we look further at what we assess on the partograph regarding the fetal condition, as I've said, we do assess the baseline of the fetal heart, and that we can do with the CTG, or we can do it with a Doppler, or we can auscultate with our ears with a fetoscope. And as I've said, we usually do that before a contraction and after a contraction to determine whether there are any decelerations. And if there are any decelerations, it is important to monitor the fetal heart with a CTG. Now, the next aspect of the fetal heart that we assess is variability. We can only assess variability of the fetal heart when we use a CTG. We can't really accurately determine variability by listening to a doptone or to listen to the fetal heart with our ears on a fetoscope. So in order to be able to do variability, we need to do a CTG assessment. And then we measure the variability in terms of good, fair, and poor. So, and then we will write a G or a F for a fair or poor, P for poor here. Decelerations, we can hear decelerations with our ears. If we do listen to the fetal heart rate after contractions, during and after contractions, we might pick up the decelerations. And if there are any decelerations, we need to follow it up with a CTG. In all cases of high-risk patients, doesn't matter what makes them high-risk patients, a CTG, the fetal heart should be monitored continuously with a CTG machine. What is very important here is that the fetal heart should be, even if the fetal heart is being monitored continuously by a CTG, that the fetal observation should still be recorded half-hourly on the partograph, because CTG graphs are not very good records, because they lose and they always tend to be lost when they're really necessary. And if there's nothing being recorded on the partograph, we have no proof that the observations have been done according to the guidelines, namely half-hourly as they're supposed to be done. Now, as I've said, another very important aspect of the fetal condition that we record on the partograph is the liquor, whether the membranes have been ruptured or not. If they are intact, we record an I. If the membranes have ruptured and the liquor is clear, we record a C, a B for blood stain, and an M for meconium stain. And when the liquor becomes meconium stained liquor might be an indication of fetal distress. So the moment that we find meconium in the liquor, it's always a very good idea to monitor the fetal heart with a CTG to make 100% sure that there are no signs of fetal distress. And that brings us to the end of this lesson. And now there's a quiz for you to complete, and you have, unfortunately or fortunately, to pass this quiz before you can carry on to lesson 1. If you don't pass the quiz, it tells you that you haven't listened very well during this session, and then you have to repeat it so that you eventually, hopefully, will be able to complete the quiz. Okay, I hope that you've learned something new, and I see you in the next lesson.